look at single mutations. So that you should be able, with enough analysis, to actually do prenatal diagnosis for any kind of mutation in the DNA. So I would predict that maybe in 2 or 3 years' time, we will see the announcement of the possibility of doing prenatal diagnosis for, let's say, cystic fibrosis using this method, non-invasive prenatal diagnosis for cystic fibrosis, which again is progress. So we can expect that because this is the ELSI issues that came out of a discussion from a biology bioethics panel at a recent genomics meeting in the US. So of course one can expect that there will be a lot more prenatal testing now that it's safe and not inconvenient and reasonably inexpensive. Then what is going to happen, as in other clinical fields where sequencing is having an impact, is that, okay, you find what you're looking for. For example, you find if there is or there isn't a mutation in the cystic fibrosis gene, but actually you get a lot more data, and in this data you can have so-called unanticipated findings. You find variants of unknown significance. You find a deletion somewhere in the genome, and then you wonder, does this have a health impact or doesn't it? And in some cases you have data to say that this maybe have consequences. In some other cases you don't have data. Then you have all the issues. What do you do about it? Do you tell the patient? Do you tell the doctor? So that means when people go into this kind of testing, they have to provide some kind of informed consent, and the informed consent has to include the possibility that there will be unanticipated findings, and so people have to decide in advance if they want to know about these anticipated findings, which means you have to explain to them before they sign the form. So it actually raises a lot of issues. And then there are also the issues of parents' rights versus the child's rights. There are cases where you can have conflict between the two. And then of course you can also have social pressures. If by this kind of testing you find a certain kind of anomaly in the child, which means that if the child is born, he will be in a way a burden on society. If the parents want to keep the child, well, whose decision it is, does the interest of society come in which way, and so on and so forth. These are not really new problems, but they're just going to be more, to come up a lot more often, because there will be probably a lot more prenatal testing in the future, and because we will get a lot more information for each test. Okay, so this is non-invasive prenatal testing. Now, I move to a slightly different issue, which is actually a lot more problematic. And this I can call prenatal checking for identity. What it means is non-invasive paternity testing, non-invasive prenatal paternity testing. So, in other words, your partner is pregnant and you want to know if you are the father. Or she wants to know who is the father. And you just send a sample to this company or any number of other companies who do this type of testing. And actually all you need is a sample of the mother's blood and some kind of sample from the putative father. like a hairbrush or a toothbrush. You don't even need to have a blood sample, so he doesn't necessarily have to know that you are doing the test. And actually, this company, I think the cost is like $1,000, and that includes testing 3 potential fathers. So how does this work? This is actually this is technically a very easy test, because what you do again is you have the mother's blood sample, and in this sample you have some little fetal DNA mixed with mother's DNA. What you do is you use a microarray. This doesn't even need sequencing. You use a microarray that looks at maybe 100,000 SNPs, 100,000 variable points in the genome. At the same time, from the same blood sample, you can isolate mother's leukocytes, so you can find out which alleles of the SNPs are present in the mother's DNA. And so the ones which you find in the fetal DNA, in the mixed sample, which are not from the mother, they must be from the father. And then you just compare these with the DNA samples you have from the possible fathers. So it's actually very easy and very straightforward technically. But it's, of course, far from straightforward from the point of view of ethics and society. So you can imagine pressure from the official father who has some doubts and wants to make sure that the child is, the fetus is from him. And if the test shows that he is not the father, he may then pressure the mother to go into pregnancy termination. So I mean, it's a pretty lousy situation. But this is perfectly legal in the US. It is illegal, for example, in my country, because in France you are not allowed to do a DNA test to take the initiative. It has to be prescribed by a judge or by a doctor, and there have to be serious medical reasons for this. But of course, you could still send your sample to a company in the US and get the results. It would have no legal value, but you would still get the information. But in principle, in France, you can be punished quite strongly. I think it's 3 years in prison and 10,000 euro fine. But as far as I know, this has never happened. Okay, so that's, as I said, this is a technically easy but ethically very problematic application. And now the last part of my talk is how do you make sure you're going to get a high quality child? So not just to avoid this or that disease, but how do you ensure the best quality? And well, there are 2 ways you can do it. One is already available. The other one, well, I think will become available in the near future. So one way is just to be prudent and to test what mutations you and your partner may be carrying. So it's now quite possible to check for hundreds of recessive mutations for single gene diseases, Mendelian diseases, and so to find out if you and your partner maybe are both carriers for some rare, serious disease. So, in essence, you check your quality and your partner's genetic quality before embarking on having a child. And if you find out that you are both carriers for a given disease, then you can, if you still want to have a child other than by adoption, then you can go for in vitro fertilization and pre-implantation diagnosis for that particular disease. And there is experience in doing this within the community. which is a Tay-Sachs disease in the Ashkenazi Jewish population, where for historical reasons the corresponding mutation had a high frequency, and the disease, which is a pretty horrible neurodegenerative disease, which leads to the death of the child at 2 years of age. So this was actually screened within the community with quite an interesting system. Maybe if you want, we can discuss it later. And this has essentially eliminated this disease from that community. Of course, there are this borders on eugenics, and this raises S issues. But if it's properly handled, it can probably be positive. But in this case, we're just talking about individual decisions, not collective ones. So again, there are companies that already provide this service. You see, carrier screening, Good Start Genetics. So they provide screening for more than 100 mutations. It has probably increased by now, and I think this is another. There are a number of offers now where you can get yourself checked for a number of possible problems. Okay, so that's one way. But again, this is avoiding diseases, and this is a little complicated, but there will be probably a way to actually select the best possible child. And this is using something which is already in practice, pre-implantation diagnostics. So it is done at this time. So again, just to remind you what we're talking about, you do in vitro fertilization. You get something like 10 embryos usually, and you can actually let these embryos grow to a blastometer stage where they have, I think, 8 or 16 cells. At that stage, the cells are still undifferentiated, so you can remove 1 or 2 cells. You can extract the very small amount of DNA that you have in these cells and test the DNA. And so this is currently done in the case where both parents are carrier for a severe disease, like again cystic fibrosis. And so it's technically possible, not terribly easy, but it has been technically possible for quite a few years already to test this minute amount of DNA to find if the embryo is homozygous for the disease or heterozygous or completely normal, which I mean, which is what's going to happen if you have, let's say, cystic fibrosis. You will have on average one embryo who has both normal alleles, 2 embryos which have one normal, which are heterozygous, and 1 embryo who is homozygous. So then in that case, then you do this testing on a number of embryos, and you take the 1 or 2 which are where the mutation is not present, and you implant those. And so you allow this couple, which would otherwise be at risk for a very serious disease, you allow them to have a normal child. So this is done. It's done in some countries. For example, it's not allowed in Germany. It is allowed in France, providing that the disease is serious. Of course, the definition of serious is something else. And just what I wanted to underline is that it is now conceivable to extend this rather than just looking at 1 or maybe 2 genes in the embryo to really get a look at the whole genetic constitution of the embryo. Because there are a number of groups working on getting a complete DNA sequence just from a single cell. And this is actually beginning to work. There's actually 2 ways of doing it. One way is to amplify the DNA and then sequence it. And there the difficulty is that you are starting with a very, very small amount of DNA. So you're amplifying very, very widely, a millionfold more than a millionfold. And so you need the amplification method to be very uniform. If it tends to amplify some regions more strongly than others, over many, many cycles, it's going to give you an enormous difference. And so then when you sequence, you're going to sequence some parts of the genome 1 million times and other parts only 1 or 2 times. And so you're not going to get data covering the whole genome. So a lot of the effort, the technical effort, is at finding new kinds of amplification methods that give you very even amplification over the whole genome. And this has made a lot of progress. This is a citation from this paper. I don't remember what the acronym MALBAC stands for, but it's some sophisticated way of amplifying a genome that gives much better uniformity than PCR. And but this is a quote from the paper, and they say that they got, well, pretty good genome coverage, and they were able to identify individual single nucleotide variations, which means they can identify mutations in the whole DNA. So this is one way of doing it, and another and probably better way of doing it is that some of the next generation sequencing systems that are coming up will be single molecule sequencing, which means they will sequence just a single molecule of DNA without amplification. And so they would be ideally suited to doing this kind of single cell whole genome sequencing. So I think it is quite certain, again, that in the near future it will be possible to get a complete sequence from one cell taken from an embryo. Okay, how expensive it will be, that's another issue. It has to be quite accurate if you want to use it for some kind of diagnosis, but things are going this way. I don't know how long it will take, but the idea is that then, to the extent that we can predict the phenotype of the child from the DNA sequence, and that extent is still limited, but it's going to, again, it's going to get better and better. Then it will be possible from the DNA sequence to have some idea of what the child will be like, what is his susceptibility to various diseases, what is his height at adult age, the color of the eyes, all sorts of things. For example, eye color can already be quite reliably predicted from the DNA sequence. It involves several genes, but we know which genes are, and we can predict which child would have blue eyes and which child would have dark eyes. And so you can imagine at least wealthy people going through this procedure and having sequence of 8 embryos determined and picking the child they want from this set and having that embryo implanted. It's not for today, it's not for tomorrow, but it's probably not so far in the future. And again, of course, then you have lots of issues that come up. So this is, I think, almost my last slide. So the message I wanted to give you is that the technology is moving very quickly, that there is demand, a commercially interesting demand from people, or in some cases, really justified demand, like non-invasive prenatal diagnosis. There are a number of difficult ethical issues, and this really needs to be taken into account in the discussions. So we try to avoid the situation, which I quite like. So you see the DNA double helix, and you see the science moving very fast, and ethics trying to keep up. maybe to end on a positive note, yesterday evening we had the decisions from the Supreme Court of the US on the patents on the breast cancer genes. If you remember, there's a monopoly by a company called Myriad Genetics on doing the breast cancer test. This is what Angelina Jolie underwent recently and decided to have double mastectomy. And there was a big fight contesting the patents, and sort of probably final decision was reached yesterday, was announced yesterday by the Supreme Court. And it's a decision that, well, doesn't eliminate patents completely, but very much restricts where those patents can be taken. And actually, I think hours after that decision, there's already one company in the US that announced they would do the test for $995. And Myriad so far was charging almost $4,000 for the test. So it's not hopeless, but things are really moving fast. Thank you. Any questions? We have
10 minutes?
Okay.
Yeah, 10 minutes discussion. So we have mothers here. Maybe my ladies has already some children. Okay.
Suspicious fathers.
Father is evolutionary, nothing, you know. So what's your opinion about all those kind of testings? Okay.
One of the things I never think about having a perfect baby. So when I was pregnant, I never think about having this. But however, yes, it's really a problem in the near future because I know that, well, some of the anxious parents really want to have a quality baby. So. Yeah, so in the near future, we will see more and more stronger babies. So maybe Superman in the beginning, I don't know. Thank you.
So is it possible to have some information about the intelligence of the baby from those genetic informations or characters?
Yeah, this.
I think intelligence might be the first, especially can we determine the mathematic genes?
No, I mean that's the issue of complex diseases or complex traits, which means things that are clearly influenced by genetics, but where the influence is exerted through a large number of genes. So. Intelligence is strongly heritable. I think it's generally agreement that, okay, if you look at IQ, which is not exactly intelligence, it's one particular aspect of intelligence, but the heritability of IQ is generally estimated to be 50%, so which means that 50% of the variation within a group in intelligence is inherited, and 50% is due to circumstances. So in principle, it should. So if it's 50%, if this heritability, 50% heritability is somehow encoded in the DNA. However, finding the genes involved in intelligence, or genes involved in autism, or genes involved in even things like Crohn's disease has been very difficult. And people have found, with the very sophisticated so-called GWAS, genome-wide association studies, they have found genes that have an influence. So one version of the gene is associated with slightly higher risk of this disease or a tendency to intelligence, but the effect of each individual gene is very small. So if you wanted from DNA analysis to have an estimate of the potential intelligence of the child, we would have to know all the genes that are involved, and it's probably 1,000 or several thousand, and to know the influence of each variant, and to then use this information. We are very far from that. At this time, from DNA, you can have some idea about the risk for a number of complex diseases. Of course, you can find out the risk for Mendelian diseases. You can have some idea of eye color, skin color, hair color, risk of obesity, difficulty for cessation of smoking and things like that. But it's a lot less predictive than most people think. The general public tends to think that DNA gives you your fate in black and white, and that from DNA you can say you will die of a heart attack at 43 years and 8 months, and that's of course rubbish. What the DNA can tell you maybe is that your risk of heart attack is 5% higher than the general population. Yes.
Is there any more questions?
Well, not really a question, but I'd like to first thank Professor Jordan for his very informative talk, and secondly, I'd like to echo his worry for this widespread availability of genetic tests. And my reasons for sharing his concern is because I see there's a difference between how these genetic tests are offered. They're often offered by laboratories rather than through medical institutions. So they're compared to physicians that are doing diagnose, they're less regulated. They're more like commercial enterprise, and that makes it more easy to be abused. And secondly, because they often offer it directly to consumers, I see the worries of Professor Jordan's even more, because now they're cheaper and there's more tests that you can do. So I do see that the urgency of bringing it under control. However, the third reason that makes it difficult to regulate is because it's often offered through internets across the borders. So I echo Professor Jordan's concern about these genetic testing. However, I'm less pessimistic about the area of PGD because PGD is offered through before the embryo is even implanted. That means you have to do an IVF, in vitro fertilization, before you can test the embryo. And IVF are, well, first of all, that means for a woman that could have naturally conceived, now she would have to undergo more risk through IVF. So that means she'll have to weigh whether it's worthwhile to undergo and give up the natural conception and undergo all the risk of retrieving the eggs and probably lowering the chance of fertilization and also all the costs of IVF, in addition to PGD, even though PGD is, but that means it's normally done in the clinic, which has, so I'm more hopeful of PGD, but I like to echo Professor Jordan's worry about genetic testing. Thank you.
Yeah, well, I understand your argument, Wendy, but first, I think that the tendency, okay, so to have fewer and fewer children, and the mother's age is going up, and so more, and of course, if the mother is around 40, the natural conception is not very successful, and so many of these mothers actually go through IVF anyway. And so that's one tendency which I think is a really strong tendency everywhere. And some people, argue that in the future it may be considered irresponsible to start a pregnancy by natural means. As it is considered more or less irresponsible now to deliver at home, which used to be the common practice like 50 years ago. Now, almost all deliveries occur in a clinic or in a hospital. And